care of gastrostomy tube, jejunostomy tube, and GJ tubes. So the gastrostomy tube is done by us, as well as by GI, as well as by pulmonary. They are doing that in the ICU when they do the tracheostomy and they do the gastrostomy at the same time. So it's all the same. Whether we do it, when you do endoscopically called PEG or endoscopic gastrostomy, that's where the name PEG comes. Then is a gastrostomy, which we do in the operating room, the open gastrostomy. So the only difference between gastrostomy and a GJ, gastrojejunostomy, the GJ tube is much longer and the tip comes here. PEG tube could be the same way. If they can endoscopically put a GJ tube into the jejunum. So, and then there's a pure gastrostomy, jejunostomy. So jejunostomy is in the jejunum. Technically, these are the same procedure. You make a little hole into the jejunum or stomach, you put a tube in, you close up the hole with a double layer, you tie snugly around the tissue, and then it's complete the diagnosis. What is the commonest reason we do gastrostomy? It's a dysphagia.
Right.
Difficulty in swallowing.
Swallowing and long term.
Well, yeah, so the commonest reason we do people stroke, they can't swallow, or they are aspirating pneumonias, they are aspirating the fluid. Those are the two commonest things. And anybody who has a throat cancer and they are going to have a radiation in the future, chemotherapy, we do prophylactic gastrostomy so we can feed them. If there's a carcinoma of the esophagus and they need a chemo radiation or future surgery, we do the G tube. In those cases, we do the J tube preferably, because then the stomach needs to come up into the chest. So whatever the indications are, that's the reason we do it. Or people who are malnourished and we want to bring their nutrition up to date, we do the GJs. The way these tubes are done, in old-fashioned ways, we used to just use the simple Foley catheter and suture to the skin. And now we have it called MIG tubes. And the disc, we cinch it down, and there is a reason for it. That creates a negative pressure. So it keeps the tube together under the skin. So when we change the dressing and we insist upon putting the dressing under the disc, we are doing two things. So we are making the disc loose, so then they leak. The first few weeks, it's not airtight and watertight. Tissue has to grow. And it's never really airtight and watertight. Okay? And that's why they leak. And it's a care. The real proper care is that you can just simply clean it, wash it, and put a new dressing on it. Ultimately, it will dry out.
On top of it.
On top of, not in the bottom.
Yeah.
We try to actually put sutures. So you guys, prevention from you guys to put dressing under, but still goes under the dressing. We just can't convince people there's no dressing under the disc.
Right.
Okay. Yeah.
Stubborn.
Well, we are creating trouble. Yeah.
Yes.
Because what has happened, you lose it, and then it leaks more. Okay. Also, when there used to be a paper in the chart when we did the GJ tube, that we used to put a number on the skin, how far the tube is out. I don't know what happened to that paper.
It never comes out.
So there is always there's number 2, 4, 6, 7. There's a reason for it. So usually between 4 and 6, that's the number on the skin. That's the length of the tube inside under. Heavier the person is, the number will be more. The thinner the person. If you go there, I did a G tube, but the number was 4, and then all of a sudden now is 2 or 1. then the tube is not in. Yeah. Okay. So those are the reason we do. Also, other most important thing is sometime the names change. We put a G tube, all of a sudden it become a gastrostomy tube on the next admission. Or we put a gastrostomy tube, all of a sudden when they come back, now it's the G tube. And we have a couple of disasters with that kind of change. Yeah, we always put a sticker on the chart, but no, there's no chart outside, so we can't put a sticker. Yeah, so the best is to write on your board, there is the G tube or a J tube. So leakage is number one complication, bleeding. Number two complication, you know, it's a foreign body inside that you could bleed for technical reason, or patient has on the blood thinners and they could bleed. In a tube which has been there for a little longer, you will get a little granulation tissue around the tube, like the pinkish little tissue, and then smells and leaks, and everybody report what is that. That's a normal granulation tissue. In the office, I usually cauterize them with the silver nitrate, and they go away. Or once the tube is removed, then everything closes up very quickly. The time where we don't want this tube to fall off is the right first 24 hours. Okay. Because all of a sudden, oops happened. Yeah. The earliest tube has fallen out, one of my patients is in the recovery room. Patient was transferred in the recovery room, they turned him over, and the tube was on the floor because it was under the patient, and then, okay. But you can't put it back in. Okay. If it falls out for the first 2 weeks, it's very difficult to put it back. Because we put a double bursting suture, so it cannot go back. If it is after 3 or 4 weeks, no issues. Then you can tube. Even if the balloon is broken, you can put tube right back in, put a tape on the skin, and we'll deal with that in the morning. When patients are at home, we actually give them the G tube. We do not tell them to put a J tube back in. They could easily be outside, but the G tube you could put back in. So it's on the floor. If the middle of the night the tube falls out, it's been there for a while, you can simply either put the same tube, put it back in, call the PA. If they happen to be in the OR, call the surgeon. If you wait more than 4 to 5 hours, then we can't put it back in. Yeah. Because the whole cruise is very quickly. Yeah. Very rarely radiology can put it, IR. They can go under the fluoroscope and guide wire through. Now what is the difference between the J tube and the G tube? It is the two important thing is with the G tube, you can do bolus feeding. Okay? It's like eating 4 meals a day. With the J tube, you cannot give a bolus feeding. With the G tube, you can irrigate 30 cc, 40 cc. With the J tube, you cannot eat 30 or 40 cc. Because intestine is very small.
Yeah,
and all it is going to do is going to put the pressure back, you can make the opening bigger, or the tube is going to fall out. So unfortunately, when people are on the J tube feeding, that automatic flush system, should not be done that way. It should be 80 cc flush, because it won't go properly. G tubes, you can do bolus feeding. J tube, you cannot do bolus feeding. Just remember, or you cannot do bolus irrigations. That's 2 important things we need to do. All right?
So when we have the 2 feedings with the J tube, if we do that, the flush is like a 20 mLs?
10 probably I will use,
10
see
to
what
20?
happens. Yeah.
Okay.
Yeah.
All right.
I would not use more than that.
Okay.
Yeah. Okay. So those are the 2 important things we need to do. Other things, let's assume your tube get clogged. That's why we irrigate them after each medication or feeding.
Right.
So sometimes it's just not possible, become like a paste. You can put like a 5 cc or 10 cc of Coca-Cola or a Pepsi, leave it there for a while. It will dissolve out. Other thing we can do is that interventional radiology has a little guide wire with a brush, so they can go through and clean. You know the nasoduodenal tube we use here
Yeah.
has a brush inside. So we can take that out and use that. And if it doesn't work, we have to take it out and put a new one. If the tube is there for a long time, you can just take it out, put a new one. Other difference is the MIG tube. When you inflate the balloon, it doesn't have a tip. It's only balloon and the tube. And if you put more than what is required, you can pop the balloon. And you may not know it. Especially with the jejunostomy, because the intestine is small, we only put 3 or 4 milliliter of fluid in there. So if you're testing somehow and it only 4 comes out, you say, well, I'm going to put more. If you put 10 milliliter in the jejunostomy tube, guess what's going to happen? Either the balloon is going to pop or now you're creating obstruction. The gastric fluid, the pancreatic fluid, the bile is not going to go beyond that thing. And then I see patient in the office, all of a sudden, doctor said the bile is just leaking out of the tube, around the tube. Is the tube feeding working? Tube feeding working as the bile is leaking, because then when they come to the office, I see the balloon is 10 cc. Some people have put it in. So jejunostomy tube only has 3 to 4 milliliter in the balloon, not 10 milliliter. So is the gastrostomy. If they are leaking around it and increasing the balloon volume is not going to correct it.
So why are they leaking? Because of that?
Well, when the tube is going in and out and the opening get bigger. Yeah. You remember both are mucosa.
Right.
So they are not airtight, watertight. We tie the suture very tightly, then we check them that they are not leaking, but they still leak. And that's just inherent in the body. Any questions? Because we have a lady, Miss Pence,
Have 5A.
and she's leaking.
Yeah, leaking.
Okay.
Oh.
But she doesn't have a traditional gastrostomy tube. What happened was that she had a complication, so this part of the intestine is brought out on her like stomach. This is the tube. She had a gastrojejunostomy years ago, and she perforated from the ulcer, and Dr. Satish went and redid the anastomosis that leaked. So then he brought this out as a jejunostomy, and there's a pyloric stenosis. So she can be fed through the G tube. So G tube is pure for drainage purpose on her. And after few weeks, when she got better and there was no infection inside, and she was on TPN, and we decided to maybe tube feeding would be much desirable, family could handle. So he put the tube in and closed up the mucosa. Okay. But it's not airtight yet.
Yes.
Okay, so it's not, and so it looks to me, yesterday when I looked at it, the tube is quite out, so tube is probably sitting right here. And when we feed it, when we bolus feed it, it's leaking. Yeah. And we tried to put a suture in to prevent you guys to put in dressing under.
Yeah.
It didn't work out.
I have a quick question.
Yeah.
Besides enteric-coated medications,
Mhm.
what makes you decide what is the preferred route, whether it's a J or G for other medications?
There's only one lumen that you can give.
But if you have a GJ, and certain medications can go through, like,
No, when it's a GJ, usually we put in the G part to drain,
Mhm.
and J part to feed. So there's only one feeding purpose,
Okay.
open.
Okay.
The GJ is put in people who are aspiration pneumonias.
Okay.
And you don't want to put a J. So it's a GJ, so G part is draining.
Mm-hmm.
So there are holes here, and that drains out, and then I made it very simple that your J part goes like this. So the G part is draining into a bag and J is being fed.
Okay.
That's how the 5A is.
Pardon?
Is the how the patient at the 5A is. There's
No,
a
that's
G
just
part,
a
there's
simple,
Yes,
just one.
yeah.
So
one
we
simple.
can only feed and irrigate, so we
Yeah.
have no, there's no drainage.
Yeah.
If it falls out, put it right back in if it's been there for more than 3-4 weeks, okay? Don't wait till in the morning, cause then it's not gonna work. If the tube falls out within first 2 weeks, we cannot put it back in, we just have to accept it. And the complication, we see the leakage and also the clogging of the tube. The clogging of the tube is most likely when we don't irrigate after feeding. People are busy, they don't flush it, and it then becomes really a paste, a hard paste. All right. So I think Dr. Ko gave the
The
NG
NG
tube.
tubes, yeah.
Okay. So we are finished with the tubes.
Yes.
Yeah. Other thing will be the drain. I think we gave drain a year ago, the fluted drains and other drains and.
Did like the JP drain and the
Yeah.
back. Do you guys remember that?
So only difference between JP is that's the little grenade.
Little grenade.
Hemovac is the bigger.
Right.
There's no other difference, the same. Yeah. So you guys were young, you don't know that, but we had all kind of drains, the rubber drain, and then there were other Saratoga drain, there were all kind of drains. So the only drain you need is a suction drain. Very rarely I put suction drain and a Penrose drain. Somebody who has a peritonitis, they are very contamination. Penrose drain can stay longer, also creates a little passage, so in the future you could drain. Alright, what is the next topic you guys want to discuss? We done the electrolytes, we done the vital signs, we done the colostomy, ileostomy, drain, G tube, J tubes. So next lecture I will suggest the post-op care of the feeding. When we should feed,
Oh,
Yeah.
when we should not feed. That's very important. Cause on the other day we had an issue on the floor, the patient, we wrote ice and chips and sips the water, and the nurses thought that, okay, sips of water means you can drink as much as you want to. Yeah, one jug of fluid was given to the patient.
Oh my goodness.
But when we write ice chip and sip of water, that usually mean to keep the mouth
Right,
Yeah.
moist.
moist, yeah, because mouth is very dry. A, they are probably behind the fluid.
Yeah.
B, most likely post-op patient are breathing through their mouth. Okay, that's where their mouth is dry. And what is the most important reason their mouth dry?
Because that fluid.
Pain medicine.
Ah.
All pain medicine side effect is dry mouth.
Mm.
Yeah. So that's why their mouth is dry. So I usually tell them have a hard candy or a gum instead of fluid. Because for you and me, ice chip might be a little ice saver, somebody else will be 4 glasses of.
Yeah.
So they are
Absolutely.
literally
Some
are clear
patients
liquids,
are like
yeah.
that, yeah. Keep asking more ice, more ice.
Yeah. Okay, so we'll see you not next Tuesday, the Tuesday after. Meantime, if you guys want to, I will do the post-op feeding.
Yeah.
Okay, and then pick up a topic, we'll discuss it, all right?
Thank you.
Okay.
Thank you.
If the